By request of the meeting organizer, this meeting is being recorded.
Our March 3rd End Disparities Learning Exchange office hours, MSM of Color Consumer Focus Group. We were originally going to have this webinar on February 24th, as you can see, but many of you know that we had some terrible technical difficulties last week that prevented us from having this program. It's a really important topic, and we wanted to make sure that we were having a great opportunity to bring you together to talk about it and to share our own experiences. So we rescheduled for today, and we're really happy that you were able to join us today for this important discussion. My name is Michael Hager. I'm the Manager of Technical Assistance and Dissemination at the National Quality Center and also the leader of the End Disparities Learning Exchange. And while we do have a smaller group, I think it's just good, for us to practice for other webinars as well. We like folks to just enter a little bit about themselves in the chat room so that we can have a sense who's on the call, and also for other folks on the call to see who else is dialed in. So I'll start. Michael Hager, NYC, NQC, and Disparities Leader. Great. So while folks are typing a little bit about themselves in the chat room, just some background for those of you who may not have participated in very many of our activities. The End Disparities Learning Exchange is a 9-month initiative that promotes the application of improvement interventions that reduce HIV-related disparities among 4 key populations, including MSM of Color, our topic of focus for today. We're doing this while building and sustaining a community of learners among Ryan White participants who are familiar with the subject matter and each other so that they can assist each other as problems arise or while you're working toward common solutions. The Learning Exchange offers informational opportunities by content experts and utilizes this opportunity of peer learning. So we're bringing you all together today because you all have something unique to contribute and add to this discussion. We're all passionate about serving MSM of Color and also achieving health equity for all folks living with HIV in the U.S. So that's a little bit about this initiative and what we're trying to do. If you're looking for more information, check out our video online. It's on our YouTube channel, but it's also right on the website, end+disparitiesexchange.org. And it's a great way to, get people excited to talk about disparities and to think about how they, as individual providers or HIV consumers, can get involved in this very important work. So what is an office hours? Office hours occur on Fridays at 1 p.m. It's a variable schedule, so we ask that you go to our website, end+disparitiesexchange.org, and click on events to see when exactly these are. No registration is ever required, and it's always open to everyone. The concept for today and all of our office hours is that we want an open dialogue with you around the situations, challenges, and solutions that you have in serving MSM of Color. And today, our focus of topic is an MSM of Color HIV Stigma Consumer
Please record your
group.
message. When you have finished recording, you may hang up or press.
There we go. And I'm just going to go ahead and mute all the lines to prevent that from happening again. And a quick reminder, you'll see that everyone now has a little orange button to the right of their name. You can click that button at any time to unmute your line and to share with us on the line. Sorry about that distraction. So I think this is actually the time for us to try to have a conversation around MSM of Color. And actually, let me unmute all. Okay, so we'll just be careful, and I'll be mindful and mute folks who are making a lot of disturbance. But the important thing to discuss is really what brings us all together, MSM of Color and stigma. And we want to have a focus group with you around what some of the main challenges are. And we'd like to root this conversation in the themes that we've had so far in the conversations of end disparities, but in particular, the Partners in Care discussion that we had last week. And so I'm wondering if anyone wants to just kind of like throw out some ideas to start us off here. What are some of the key stigma-related barriers that are important to you in terms of being an MSM of color or serving MSM of color, and maybe we can create a list that we'll try to tackle the other side once we have a list going. So who wants to get us started and throw out some ideas?
Michael, this is Judy. Although I'm not a consumer, but one of the things that hit home with me was interesting last discussion was how MSM of color are looking for providers that are more like them and are, you know, more easily relatable to, or whatever would be the appropriate terminology, just to feel like they fit better with their providers.
Great. Thanks, Judy. Who else has some comments or suggestions on barriers that are related to stigma? Hey, Robert. Ms. Dolores, was there anything in particular that stood out to you last week when we were talking with our friends?
Yeah, well, I hope you can hear me.
Yes.
Great. So I know some of the themes that came up was a concern, an ongoing concern about access to health care for the population.
Thank you. Press 1 to accept this recording. Press 2 to listen to it.
I'm sorry about that. Go ahead. Access to...
access to affordable health care, specifically for this population. And that was in different parts of the country. So it wasn't everywhere, but it was mentioned that there were different parts of the country that still were experiencing issues around medication. There was a discussion around the need for holistic access, taking into consideration all the issues that impact the individual as they're provided medical care. So, you know, I think we need to explore those barriers that were mentioned.
Thank you so much, Dolores. I don't know if anyone else has additional thoughts. This is a great list that we're building here.
Dolores, Michael, this is Debbie Cicero-Seifer with various AETCs, and I just wanted to add to that I thought that that where we start and where we really miss, I think, the mark is in just doing general sexual health histories. And I'm coming from a provider standpoint. I'm in and out of many primary health care centers, urgent care centers throughout the South, in the Caribbean. And where we may really be missing the mark is in that very first contact where we don't have that very holistic and non-judgmental approach to the way we talk about sex and the sexual history that is so vital in order for someone, for anyone, for us to take good care of ourselves. And that is part of holistic health care.
Great. Thanks, Debbie, and welcome. And, you know, I was looking for you at the beginning. I'm sorry that you must have had an issue accessing again, but I'm so glad you've dialed in. Debbie Cicero-Seifer, as she mentioned, is with many different AETCs and has a strong track record working with many different populations and especially working with groups on stigma. And so we're really happy to have her with us on the line today. And, you know, she's helped us with a couple of our other end+disparities learning exchange opportunities. She brings a wealth of experience and knowledge, and you know, she's added a lot of value, as I said before. So thank you, Debbie, and welcome. And I don't know if there's anything in particular, any other questions that you wanted to focus on. You're not able to see, I don't think, but what I'm doing is I'm just typing in a whiteboard in the webinar itself, some of the notes that we've had. So I have all 5 comments that have currently been made, and yeah, I don't know if you want to take it away from here or you want me to keep going.
I've got a comment.
Yeah, I love where we're going, so I'll make sure that everyone is heard at this point.
Wonderful. Sir, go ahead.
This is Jerry Bedford in Cincinnati. One of the things that I'm concerned about is aging of this population of men of color. MSMs, mental health issues, isolation, those types of issues I have not heard anything about.
Right.
Those are so important, Jerry. Thank you for adding those. And I might even add on to that fatigue. The fatigue, and
Yeah.
This is across all ages, but there is a fatigue, and I actually just did a presentation on how do we measure fatigue and what does that look like, because there's many reasons why someone who is living with HIV may be fatigued, and certainly the aging process adds another dimension. So thank you so much for adding that.
Thanks.
Who else has some ideas? I see folks have dialed in from all over the country. So I'm sure that there are some needs or some concerns that are unique to folks in your neck of the woods. Let's share. Go ahead and mute Jenny. So Mina, I see that your hand is up. So I don't know if you'd like to speak now or if that was a question. Okay, so let's look at.
Michael, I want to add one more onto the list.
Go right ahead.
And specifically as it relates to stigma, one of the things that emerged was there was a need to address some of the misconceptions, stereotypes that exist around the population of young MSM and finding ways to combat that.
Great.
Can I please add to that?
Yes. Thank you, Andrew.
Hi. I am a MSM, receiver of HIV services. I'm not of color. I'm located in Syracuse, and I was referred to this focus group by my peer, actually, because this situation actually came up just in conversation while I was checking in with my peer. I said, you know, I bet that straight, cisgendered men of color are a very underrepresented, positive, HIV positive, cisgendered men of color are a very underrepresented group in the HIV community. And the reason that it came up was because a friend of mine was just telling me how he just had a conversation with a black woman who was relating a story about a black male friend of hers who had an HIV situation. And the women had to make very clear amongst each other that this black man did not receive his HIV infection from another male, but that he clearly received it from a female, and that his HIV status was in no fact related, was not related to the fact that he was gay, or the fact that he wasn't gay, whatever. So I think there could be a stigma related to people seeking care or adhering to care as far as what the other members of their social community might consider their social status to be if they were to be found out that they're HIV positive. So just coming from a client side of view, everything that I've heard so far is very provider professional. I'm sorry, I hope I'm not wasting anyone's time, but I just think that there could be a lot of anxiety there from people actually trying to seek care or, you know, going from step one of getting the positive diagnosis and then suddenly thinking about how the entire world is going to come crashing down around them. If anyone were to see them walking into a clinic or talking with somebody that looks like a provider, you know,
yeah, that makes a lot of sense.
All these situations are very different for these people because I recognize that I'm just a white, middle-class male, and I just walk into clinics and whatever. People can't tell if I'm the doctor or if I'm the patient, honestly. But for other people, especially in the Syracuse community, it can be quite obvious at times. which person is the patient and which person is the doctor. And I think people might fall away from that.
Thanks for that. You know, in my experience, I've been positive for 15 years myself, and, you know, in working in different parts of the government and working in different areas of the system, you know, our cisgender, heterosexual, African-American male friends definitely feel left out and definitely feel that they have a lot to kind of explain or make up for. And I think that, you know, in terms of what it means, this trauma and trauma-informed care, care-seeking behavior and assumptions about people, and also thinking about fatigue, like that must be extraordinarily fatiguing. You know, we are focusing on MSM of color today, but I think that just thinking generally about, you know, an entire population and the subset in which this population is kind of drawn from is really important too, in terms of thinking about the distinctions that we're trying to make, and also nuances in the way that we can work to help to counteract all of these things, which I think are all social ills. Great. So, you know, we've been talking for about 20 minutes now around some of the barriers. And for those of you who are on the phone who don't have the benefit of seeing the notes in front of you, let's go ahead and rehash those. So, 1, looking for providers who are like them or at least easily relatable to their life situation. Ongoing concerns regarding access to affordable health care, and that's something that is both urban and rural, depending on where you are in the country, and the service mix in your area. Need for holistic access to care, that all of our health needs are met, is really important. General sexual histories and competently discussing with these guys. Make the most of the very first contact with these men to empower and engage them effectively. We need to think about the aging of the population, mental health and isolation, and our goal should be on optimal care. Health services fatigue, people's ability or willingness to keep up with medical appointments. And then we need to address the misconceptions and stereotypes about especially young MSM of color, but folks of color in general. And then trauma or lack of trauma-informed sensitive providers, and care-seeking behavior and assumptions on social status based on HIV status. Anything else we want to add before we start thinking about some of the solutions that we have available that are discrete and focused on any of these individual pieces? So I see in the chat room someone said particularly assumptions around recreational drug use. And I think that that is one of the core, you know, when we think about, you know, drug use, we think about sexual, what did Amir say last week? Hypersexuality, or the sexualization of these men, important as well. So thanks, Freddie, for that.
I would add also disclosure. I mean, as we talk about this, the anxiety, it goes with disclosure of who you are and how difficult that is. I mean, based on the wonderful words of our last speaker, what it's like to not be able to be authentic, and the trauma that comes from that, to not be able to be who you are because you're trying to be visualized appropriately and not be judged, and what you have to do that, which is exhausting. I think that's a part of this whole multifactorial barrier, if you will.
Specifically, I'd like to add, and I'm always very scared to add anything, because as I mentioned, I'm in that, you know, privileged white middle-class male area, but I think it's still more difficult for men of color to be openly gay in today's world, even though it's 2016. I mean, they're just marginalized in so many ways. That's still another way to marginalize a man of color. So just to add.
I think that's a great addition. One of the things that I've noticed that we're not talking about, we're talking about inter or transcultural experience, because even within cultures, there are stigmatizing conditions among cultures themselves. And then when we look at trans culture, when we're looking at all the cultures, so this is definitely layered, multi-layered. But I always also like to look at what are the strengths, what are the things that are going right? Because when we look at this huge list that we have going, it is overwhelming, and it's hard to know where to start first. It is important to know what our resources are, but I also like to know that we're getting our resources from things that are going well, for situations where we say, hey, they got that right, or that program is doing something very special, and consumers who are engaged in that program are having a different experience, the one that we're all trying to create in regions where the experiences are very negative. So I'll just put that little caveat in there.
Huh. So maybe that's the next question then, Debbie, is we should have folks start to tell us what's going right, and then that way we can kind of keep a list of that, which will empower and energize us and also help us maybe connect dots between things that aren't working well and things that are working well to see what we can do next.
Sounds great.
Okay. So I don't know if anyone has any solutions that they've tried that's going well, or anything that they've observed or felt or experienced that feels it's going well. What are the solutions that we're already doing, and what in the field should give us hope? Has anyone tried Wellversed or His Health? Are there any particular education or training programs or online modules that anyone wants to recommend?
I feel like I'm talking a lot here, but just to break the silence, again, from the consumer perspective, one thing that was done very well for me, and again, I'm not a male of color, but when I was first introduced to my peer at my immune services clinic after I was diagnosed positive, HIV positive, I was actually introduced to two peers at the same time. One peer was a white male, and the other peer was a black female. And I think that that was a very wise thing for that peer advisor group to do, just to make sure that their peer would appeal to as many different audiences as possible during that first initial impression. And it worked, because I check in with my peers.
Allegheny Health Network offers a network of fully licensed testing facilities that are conveniently located at numerous community sites.
Sorry about that, Andrew. Go ahead.
I check in with my peer almost every time I go to the clinic, or at least I ask if he was there, because he was the first point of contact I had after that initial diagnosis for, oh my God, how do I pay for services? Where do I get services? What's the rest of my life going to be like, etc. And it's been that peer that has been the overwhelming resource for me throughout the entire experience. So just the fact that they made sure that there were two different people there to appeal to two entirely different, well, many different groups of people, I think that was the very first thing that they did absolutely right.
Thanks, Andrew. Who else wants to share? And just a reminder that you may be on mute, and you can click the little orange button to the right of your name to unmute yourself.
Hello, can you hear me?
Hi, yes. How's it going, Freddie?
It's going well. Sorry, I didn't notice about the mute button. I'm calling from the Department of Health, so I wanted to share two main strategies that we're using. One is directing a sex-positive message for everyone, which is one of the key guidelines that we have. And then there's another one more specific to geographical areas and being on the field, which is the beautification of clinics. So it's pretty much investing on sexual health clinics that are on these marginal areas that have a larger population of people of color. So the idea is to kind of set a minimum standard that's for everyone and not have people marginalized both geographically in terms of resources. So we shouldn't really be having a difference on a clinic that's based in Manhattan versus one in Crown Heights in Brooklyn. So that's part of the initiatives of bringing equity and equality.
Beautiful. Thank you very much. I agree that, you know, the first thing you see, as anyone who's ever received any health service, which is definitely all of us on this call, you know, the first thing that you see definitely makes you feel either confident or comfortable or something else with the services you're about to receive. So that's a great point. Thanks, Freddie. I'm entering. Oh, go ahead.
I've got, well, let's see. I work with a group of positive infected men. We have a support group. When I started the support group along with 6 other guys in 1999, I was 44 years old, and everybody else was in the age range of 30 to 40, and some in their 20s. The group is still going. I'm now 62, and mostly everybody in the group is now 50-something. And as a result, this group has participated as an advocacy-type group. We have educational sessions, we have social sessions, and we do a variety of things to keep people engaged. And I was the one that brought up the comment about social isolation and the aging of the population. And I think it's important to stay engaged with people and to just keep them going with some activities, you know, to keep people from being socially isolated. You know, we've lost a few people over the years. In fact, I think I'm the only person that has survived out of the original group from 1999. But so that's what's been working for us here in Cincinnati. The group's name is called Positive Souls. S-O-U-L-Z is how we spell souls.
Positive Souls.
S-O-U-L-Z.
Okay, cool. So, Jerry, I have a question for you on that one, and I love it. I think that is one of the things that's helped so many folks over time. Since it is an ongoing group, it sounds like there's been exit points, which is not the fortunate type, you know, people passing away. But what entry points do you have as well, and how does a group that's been functioning and building comfort, you know, with each other for 10+ years welcome new members in, and what's that process like?
Before I mention that, we've had some exit points where people have gone back to work. And some people can't attend because they're now working full time. And especially, you know, those that were homeless, substance abuse, and all that, and now they're working. I think we've accomplished some things in that respect as well. But we get, we get our word out to various websites. There's a local United Appeal agency that has our name and telephone number, my name and telephone number as a contact person. The AIDS Service Organization has our information, and they constantly refer people to me, you know, to be part of the group. And so the word does get out. We're actually known across the state as Positive Souls, and through some of our participation in some of the state-level prevention efforts, and with the Minority Health Agency of Ohio.
Wonderful. And that's such a great organization. You guys do great work in Ohio. Thanks for sharing, Jerry.
Thanks. Okay.
Jerry, this is Debbie. I just have a question for you. Many of the individuals who I've been seeing in clinics who are aging and doing a fantastic job of learning to age gracefully with HIV, no matter what their culture, whatever, what their color. Many are challenged with survivor grief. Does your organization spend any time helping people through that?
We are connected. The agency that we're based at is a mental health agency, and we do have some individuals who have been referred for counseling, especially for that guilt, survivor's guilt.
Thank you. I thought we should add that in as well, and I'm thrilled to know that there is support, not only peer support, but then professional support as well, to wrap our arms around individuals who are challenged and really trying to cope.
Yeah.
I see our friends at Albany Medical Center have their hands up. Is there something that you'd like to share?
Yeah, I had a question for Jerry and Andrew, as they have so graciously, you know, talked about their experiences being HIV positive. I'm a young nurse. I work at Albany Med, and I was wondering if they had any ideas. I think it's a great that, you know, Jerry talked about his group and how a lot of the individuals, you know, have been going for a long time. I was just wondering if they had any ideas of how we can kind of initiate like a sense of camaraderie for a group of young people so that they, you know, they support each other and they carry on these same behaviors that he seemed to, you know, instill in himself, and to just like move forward after being diagnosed. Like if they have any ideas of how to reach out or kind of like create something like this for the younger group.
Unfortunately, it has been my experience, the younger group doesn't seem to latch on to the support part of it as easily as we did back, you know, years ago. I think stigma, that's the problem area, is that stigma piece, because stigma prevents people from doing a whole lot of things. And one of those is even being associated or around people who are HIV positive, just like they are when they find out that they're newly diagnosed. And they just don't believe that it's happened to them, and they don't believe that they're actually ill because nothing has happened to them as of yet. And so that's a hard crowd to reach. We've tried different things. We've had poetry slams. We've tried working with, trying to incorporate poetry slams, and we also try to make sure we do something for World AIDS Day every year or something for National Testing Day. We try to be involved with that so that, and try to appeal to young people in those particular ways. And we also try to participate with, like, gay pride, you know, passing out condoms and information. So we've tried working through that type of avenue with the young group.
Jerry, I can speak to that directly. As you can see on this WebEx, I've only provided my first name. I haven't provided my last name. And I am a young person who's HIV positive, and I am very, very worried about being stigmatized in my own community, within my own family, within every social group that I participate in. Just being in this focus group is sort of a new thing for me. I've been indicating interest in getting involved in my own peer advisor group that I told has been providing so much assistance to me throughout this experience. But it's a long process to personally come to terms with the fact that you're probably going to be okay, and the world is really not out there to stigmatize you. You know, but it's everybody has their own speed. And personally, what I've found to be most helpful is my one-on-one relationship with my peer. That's been my #1 resource. It's very discreet. I see him in the clinic behind closed doors. It just becomes a part of my regular health visits. So honestly, I would say that establishing a really effective peer group and then having peers available that appeal to your people. What I also wanted to add, I've been doing a lot of research for college recently, and I came across an article about, and it's a little bit of a stretch, but I don't think too far. It was analyzing men of color who are suffering from depression and anxiety, and the fact that more often than not, they reach out to members of their clergy in their communities before they reach out to members of their medical services for help with their depression and or anxiety. And then those same clergy members were surveyed, and the majority of them responded that they felt unprepared and did not have preparation to provide resources or referrals for these people. So what I would like to posit is, to the members of our health services on this call, are you aware of any programs that you either host or participate in where your health services organizations are reaching out and interfacing with your religious or clergy members of the communities to try and identify the people that actually need assistance and aren't getting it or are having trouble with adherence? Are there any programs like that that anybody on this call knows of? Because that seems like a huge hole, maybe. Maybe there's like a political barrier there that I'm totally unaware of, but, you know, as far as getting people connected with services, that's just a piece of research that I actually came across. You know, it's like, it's APA research, it's actual stuff, it's out there, it seems very reasonable, but, you know, do we even have any clergy members on this call?
You know, we have here in Cincinnati, this is Jerry again in Cincinnati. We've been involved, or had been involved, with the Balm and Gilead that Professor Snell started some years ago. And we have actually had some training with the medical practitioners, our doctors at the Infectious Disease Clinic, which is our treatment center for most of our patients, and with our clergy as well. And every year for the past 15 years, we get together for a dinner. In fact, the dinner is coming up next week on March 9th. And at that dinner, we all just get together. We have resources. We got all the different agencies that are involved. Everybody has a chance to get up and talk about their agency, what they're doing. We have nurses. We have doctors. We have the clergy representing different religions. My church is involved with it. And we just get together and just talk. And for whatever reason, that seems to work around here. It's been working for the past 15 years. So that's... And do those clergy that get involved, do they actually go as far as putting up, you know, maybe like a flyer on their bulletin in their church or whatever building that, you know, has a red ribbon on it or something like that? Right. Actually, I make sure that happens in my church. I know for a fact, I've actually given a couple of speeches about some of our local statistics and, you know, being a resource person for any of those types of questions. I've made myself available to the minister and told her there's a wealth of information out there, but you got to let me know what's going on if, in fact, somebody needs that type of information personally. And so it's worked in my church, and I know of several other churches where that has worked, and people are actually doing that. Excellent. That was exactly what I was hoping to hear.
Yeah, I've heard similar stories from other parts of the country as well. You know, I was actually in a training last week in Seattle, and the same question was raised. You know, there were 120 people in the room, and someone said, you know, for me, the church is really important, and I've received a lot of, you know, service, you know, and ministry there that's helped me with my HIV. Are there any, clergy in the room? And it was surprising. There were quite a few folks actually who raised their hand in some way or shape or form. They may not be ordained, but, lay folks. And it was nice, too, kind of talking about the diversity of what that means, too. That, there were folks representing Catholic background, Protestant background, Baptist, and even some folks who from the Jewish background as well. And I think that when we think about stakeholder engagement, because this is really where what's sticking for me, is when we're thinking about a strategic plan about what we can do as a region, we need to include those folks on the list. Stakeholder engagement just isn't thinking about our board of directors and our consumers, but it's thinking about our funders, it's thinking about other clinics in our area, it's thinking especially about those other service providers in our area who are serving the same patients. If I'm a medical provider, I should very much be engaged with the food service, housing service, behavioral health service, transportation service providers so that I have a good sense of what the broader needs of my patients really are, and I'm not just guessing or relying on information that we've captured ourselves. We're so much stronger when we work together. And by engaging folks in clergy or in barbershops, or if we're talking about youth, places where youth hang out, even thinking outside the box, if it's 7-Elevens in your area where there's a lot of youth hanging out, talk to the owner of the 7-Eleven. Just some ideas to kind of build off what Andrew and Jerry have been saying. I'm wondering if anyone has any comments on that or feedback or any experience that they'd like to share.
So this is Dolores, and for 6 years I worked with faith-based organization doing HIV/AIDS awareness. And I think what we have to acknowledge is that while there are many people who are in faith-based setting and they go there for not only spiritual but mental support, there have been some barriers that exist in those settings. And I think there is an ongoing need to keep sensitizing faith-based organization about the needs of our population, especially the needs of our young folks. I have met many church leaders who are supportive and receptive, but there are others who are stuck in their dogma. And so I think there is a need to identify those leaders who are willing to learn and to understand more about HIV and willing to meet the needs of the population. So I think there's still a lot of work to do. I think Balm and Gilead really do a great job, but there is room for improvement.
Hello?
Hello.
Hello, this is Jackie Dozier.
Hi, Jackie.
How are you?
Good, how are you?
Good. Can you hear me? Because I can't hear you.
Oh, we can hear you.
Oh, I can hear you now.
Okay, wonderful. So what comment would you like to share?
Again,
go ahead.
I'm from Trillium Health in Rochester, New York, and work in the prevention department. But we do a lot of work with the faith community, as well as working with barbershops and beauty salon initiatives here in Rochester. We actually meet on a regular basis with some of our faith leaders. But I wanted to just say that it has been very difficult when we talk about providing services to our young Black MSMs, mainly because of who we are as a culture. And so sometimes it's hard to get buy-in from the faith community to engage in just simply having those discussions. I always like to joke, it took us like a few years to even be able to sit at a table and say the word sex, at a table of clergy. And so we've gotten past that, and we've begun to talk about how do we begin to bring this topic of our young MSMs to the table, particularly in communities of color, because of past history, if you will, particularly in the Black community. And so when we, you know, talk about marketing and outreach and that kind of thing, yes, I do believe that the Black church should be in the forefront of everything that goes on in the African American community. I do believe that, but it's a step-by-step process when it comes to Black churches. And the other thing is because what works for other cultures, particularly white culture, LGBT, does not work for the Black community. And so we have to think about those things because for us as African Americans, we live on axiology, which means we, you know, we're relational people. We build relationships. And so building relationships, you then get that trust, and then people are more apt to sit and listen to you. That's my 2 cents.
Yes, hello?
Hello.
Hi, this is Orbit Clanton from New York.
Hi, Orbit.
Hi, I'd like to just share my personal experience with the faith state and HIV. I happen to be a member of the second largest African American Baptist church in Harlem. And a plug for the church, we're celebrating our 75th anniversary.
Oh, cool.
And I am the president of our HIV/AIDS ministry. And over the years, I've learned the history. In the beginning, it was not easy. The church was reluctant. But this past World AIDS Day, which we now have a whole week that we call AIDS Awareness Week. And that Sunday, I stood up and gave an emphasis about World AIDS Day, the typical statistics of current numbers that are going on. And then I ended my emphasis with a testimony, and we're talking at least 600 to 700 people in the service. And I started off saying, what is a miracle? What is the definition of a miracle? Then I and said, well, you're looking at a miracle because I'm HIV positive right there within our 11 o'clock service, and that was a major, major milestone. And part of what I'm realizing, because several years prior, I wanted to disclose, and those around me who cared were like, I don't know if they're quite ready for that. But I'm seeing that the church is slowly coming around. And when individuals stand up and disclose their status openly, and I'm not saying that anybody and everybody can do that, because you have to get to a point where you feel comfortable in being able to openly disclose. I've never said openly that I am a African-American gay man, but I've been in the church long enough so most folks have figured that part out. And it's standing up and being confident in who I am is starting to make a difference. We are blessed to have a grant from the city of New York that is reaching out to the faith-based community, and it's called New York City HIV Enhanced Outreach Grant. And what we do is this group of churches in all 5 boroughs that have AIDS ministry. We go out into the community, we offer testing, and what's happening, especially to MSMs, they're starting to see the change in the church. And I think I wanted to share that with you all.
Great. Thank you so much for sharing that. You know, I'm thinking about the comments that the last folks have made, Andrew, Orbit, Jerry and others, you know, and a lot of the feedback right now is coming from the North. And, you know, I'm thinking about what folks have said in the chat room, like, what about rural and, you know, keep in mind that things don't work in the South. So I'm wondering if some of our friends on the line who are from the South or from more rural settings can share a glimmer of hope that they've seen in terms of something that has worked or, you know, has great promise to help MSM of color in their communities. You know, I'm particularly taken by Chris Scope's piece, that stigma is a huge thing in the South, and it complicates individuals to share their status, because the South is a very private culture, you know, where you don't necessarily wear your emotions or your feelings on your sleeve, and so it's kind of additional layers that you have to get through. I'm wondering if anyone has an experience working around or through that.
This is Debbie. I spend a lot of my time working in the South, very rural areas in Central Florida, the Panhandle, South Florida, and we're very concerned about how do we pull religious leaders into the conversation, because it's important, no matter who a person is, that their religious or spiritual needs are being met. And in Miami, we were so worried about it that there are huge billboards that are up that have individuals, pictures of individuals who are HIV positive. One gentleman is a renowned chef at one of the restaurants in Miami, and he is Black MSM. And one of the posters says, "I am HIV positive and God still loves me." There is a feeling among many of, I think, our people living in the South who are HIV positive and men of color, that God has abandoned them. And so we are reaching out. The AETCs now have HRSA has instructed us to go out and to reach out to spiritual leaders. The Adventist Church, for example, even though the Adventist Church's motto is abstinence, I've been able to meet with parish nurses and find that they want to talk to their congregants about sexual health. And there are many people in the Virgin Islands who attend the Adventist churches who are Black MSM. So, you know, taking just one church at a time or taking an entire organization of churches and finding your champions and that's what I'm hearing from many of our colleagues in the Northeast and maybe even in the West. The South needs to do more of this, but we have to, unfortunately, we have to do it very carefully, because I'm being told that oftentimes we could create more of a problem. So it has to be done with care, with consideration, and
trust.
Right, trust. Thank you. Thank you. And it gets back to the relationship.
Yeah.
So that is key. And development. And development, we're all in developmental stages. And as I've been hearing everyone speak, the one thing we also haven't looked at when we're looking at young men living with HIV and maybe unable to bridge some intergenerational experiences and connect, a lot of that has to also do with where we are in our development when we're 17, 26. Our issues are different too, not just our culture, but the issues that face us as young people.
Right. I'd also like to say, this is Jackie again, that this coming up week, starting on Sunday, is National Week of Prayer for the Healing of AIDS, and it's a whole week of services, and it's something that I coordinate every year, been doing for the last probably 15 years, where we have 7 churches who are actually host churches for every day or evening until next Saturday. And so we had actually bring in community folks from other CBOs as well as community people and people who are HIV positive to speak on HIV and the stats here in New York State around our young MSM. So that'll be happening starting this Sunday. We also have a interdenominational health industry coalition where we will also be utilizing some churches in the community. And so again, I think it's a step-by-step process and engaging our faith leaders and just beginning to have the conversation because it's a difficult conversation for communities of color to have because, and I agree with the gentleman, churches have come a long ways, but we still have a long ways to go. So there's quite a bit that we're doing here in Rochester and at Trillium Health as well.
So I want to take a moment just to share a couple of resources with you all. Since I have you on the phone, this is a conference that is nationwide. It is May 22nd and 24th in Harlingen, Texas, which is the very, very bottom tip of Texas. It involves Latin American consumers and Latin American providers from across the country. They even have folks coming from as far as Alaska and Hawaii. So it seems like a really wonderful opportunity for folks to kind of engage with each other around many of these core issues as they affect Hispanic men. And, you know, there's a lot of intersectionality there. You can click for more information. This is another one, Transforming Care Conference, and we haven't talked much about the intersectionality of trans and MSM of color, but there are plenty of folks who are identifying as gay men who are actually trans. So it's important for us to keep in mind all of the ways that we can, you know, work together. So the Transforming Care Conference is actually from Jerry's home state in Ohio, but it involves people from all over the country and is also a really wonderful opportunity for us to learn from each other. At the beginning of the call, I asked folks if they had heard of Hiv Health or Well-Versed. Hiv Health is a educational tool for, oops, someone's talking, so I'm just going to have to go ahead and mute.
This message was sent to Julie Baker or something.
All right. So Hiv Health is a tool that you can use as an HIV provider to learn more about engaging people around their health matters and health concerns. So a lot of the issues that were in red at the beginning, thinking about assumptions or the way that we speak with people competently about their lives and their health care, Hiv Health is good for that. And then on the other side of the coin, if you want, you know, MSM of color, particularly young black men, to have an understanding of their own health and how to engage with their providers in their health, because sometimes that's the other side of the coin too, right? We have to know how to ask the right questions of our provider and how to interact with our provider. Well-Versed is a great tool that helps folks learn those skills. Next, we have some resources from SAMHSA. We had talked a little bit about behavioral health data being important for us to make decisions, to have an understanding what's even happening in our own communities. And so this database actually is all of the nation's substance use and mental health data aggregated together. And from there, what you're able to do is to, you know, look at, you know, your own region. So it's benchmarking data that you can use to have a sense of what's happening in your clinic, what's happening outside your clinic, and how that fits in with everything overall. And along that same line, we have a resource here that's like the NQC Share Lab. That's all of the SAMHSA interventions that are focused on behavioral health and substance use. So the cool thing is you can identify within your own patient data and using the benchmarks opportunities that you can then address using specific behavioral health interventions that are listed here on this website. Two other things that we've talked about quite a bit, but you may not be aware of. The People Living with HIV Stigma Index is something that Ms. Dolores is involved in. Dolores, I don't know if you want to, you know, provide a plug here instead of me yammering on.
Oh no, but you're doing a great job. But again, the people living with HIV Stigma Index is really a survey tool, and its attempt is to survey the people living with HIV and to ask them questions about stigma that they experience in the community as they access service or just living with HIV. The good thing about the Stigma Index is that it is a tool that is delivered. It was developed by people living with HIV. It's a global tool used in several countries, and it's an interview interaction, and the interviewer is a person living with HIV interviewing other people living with HIV. So there's that peer component. And in many ways, it's also an intervention because those interviewers are trained to do interviews. So this project was rolled out in Detroit, Michigan, in Louisiana, and is now being rolled out in New Jersey. You can get information on the Stigma Index on their website, and I think you have that up. But definitely it is a tool that has been tested and can be used by anybody. The administrative body in the U.S. that oversees the Stigma Index is the People Living with HIV Caucus.
Great. Thank you so much for that. One other thing that I just want to show you is the Health Policy Project, and this is looking at it from the other side. And I think many folks were talking about feeling stigmatized or concerned about a potentially stigmatizing environment for care. And what the Health Policy Project does is it looked at what is core, what's common behind what's happening in terms of stigma and discrimination within clinics around the world, and found that there are actually 4 or 5 core elements that are common no matter where you are. It's a human nature thing. It's not a location thing. And so this is a tool that you use as a provider to assess your own staff about the stigmatizing environment that you may or may not provide for your patients, and then comes up with really great catered toolkits that you can use to educate and then maintain the professional and destigmatized environment in your clinic. So I just wanted to share all of these different websites with you. I'll include them all in the email that you'll all get afterwards. And yeah, I don't know if anyone has any questions or comments or concerns before we end today's focus group, but I'm feeling really energized. I think that we had a great conversation today and lots of great information was shared. I don't know if anyone else has any comments they'd like to make.
Michael, I have one question.
Oh, yes.
So my name is Kay. I'm a nurse at Albany Med in Albany, New York, and I am also a young person. And we've been talking today about, trying to address the younger population of individuals who are diagnosed with HIV. I was just wondering if anyone had experienced or has any thoughts on positive or negative aspects of trying to raise awareness on social media, like the use of Facebook and Twitter and Instagram, Snapchat, all of those things. Do people find that it's positively or negatively affecting, the stigma against HIV? Do they feel like it's getting better, getting worse? Or also I'm wondering if they feel that it would be a positive or negative means of spreading awareness and providing education, and or maybe even just having like a sense of camaraderie.
Hello. Oh, I can answer that if you don't mind me picking on the topic.
Go right ahead, Freddie, and then we can have Orba answer next.
Okay, so what we are doing in terms of communication is trying to be as neutral as possible regarding the HIV status of the people we're talking to. Mm-hmm. So the strategy that we just rolled out last year was talking about taking medications to treat or prevent HIV. So we are addressing people who are HIV positive and negative without making a difference, because if you look at it from the perspective of what we're going to be doing with him, is both trying to get people onto medication, regardless if they're negative or positive, because if they're negative, they will be on PrEP. If they're positive, they will probably be taking the same meds. So there's no real difference between one being positive and one being negative. So we're trying to reach out people like there's no difference, and at some sort of subconscious level, people get the idea that everyone's getting into care.
Great. Thanks, Freddie. Orbit, what were you going to say?
Yes, I wanted to say, first of all, next month marks 35 years I have been living with HIV.
Mm-hmm.
And
wow.
So I've seen the entire epidemic and especially the stigma aspect. But with social media, as a matter of fact, I invite each and everybody on the call to like me. It's my name, Orbit Clanton. And on there, I openly disclose, the section of that you put about you, long-term survivor, HIV positive. I share information, and the feedback is good because it's a process to openly disclose because of the fear, the stigma, and all that. But for those who are comfortable and have reached that point, social media is an excellent tool to break down stigma by just sharing your story, letting people know that you're HIV positive, and educating them about the facts. Because, like in the South, well, actually anywhere across the country, there's still a lot of uneducated individuals about HIV after the epidemic technically is 36 years, and still people are fearful of HIV. And I encourage those who are at the point to come forward, because one of the greatest ways we can break down stigma is for individuals to see and meet or hear, if it's social media or social interacting, that you're HIV positive, and you have to be comfortable with yourself. But I definitely believe that I've reached that point. But then you could say, well, over 35 years, yeah. But when I disclose, surprisingly, I've had people to say, you know what, you're the first person I've ever met who's HIV positive. Now, in the back of my mind, I'm saying, yeah, the first one who's ever openly told you.
Amen.
But the good thing is when they meet you and then they realize those fears that they had about you and all those misnomers, a lot of times they do break down. Thank you.
Thank you so much, Orbit.
Thank you.
So we're running a little bit.
I just wanted to add.
Oh, go ahead.
I'm
Andrew.
sorry. Just really quickly, one last thing. And this is going to be a little distasteful for some people, but as far as social media and directly impacting individuals, I have performed more sex education and one-on-one conversations on Grindr than I have anywhere else in my entire life. So if there are any outreach workers that are sitting there waiting for calls on a crisis line or something like that, give them an iPad, put Grindr on it, and for this tagline, say, you know, whatever, regional HIV center. People will contact you and ask questions, and you will be amazed at how uneducated people are about basic STD information.
It's very true.
Yeah, this is Dolores. I just want to support that because we do use, especially that website, Grindr, in one of our programs to do outreach to young MSM, and it's reported that it's been very, very effective. So I really want to support that.
There's no stigma. It's private. It's a kid in his room with the door shut. You know, nobody knows what he's looking at on his phone. He's learning about STDs and HIV. It's great.
Beautiful thought. And yeah, absolutely, I agree.
There was a program in Maine when I was doing that for the rural people. This was in Maine. There was a regional HIV care center in Maine that was reaching people rurally through Grindr. That was the exact point of it.
Great.
Just a quick comment. Yesterday I was in a meeting with Los Angeles, and they had applied a similar strategy, reaching out through Grindr particularly, posting up an actual profile that would talk to people who needed information. New York has not done it. We will probably start doing something similar very soon. And particularly for the people out there in smaller cities, that's probably a very economical way of reaching out. So I think this is a very apt strategy.
Fantastic. Albany, I see that your hand is up again. I don't know if you have any last comments or thoughts. Or Luis Solare, I don't know if you had any thoughts. I saw that your hand was up. It's now down, but wanted to give you the chance anyway. All right, everyone. Well, thank you so much for taking the time to join us today. I'm going to go ahead and put together the chat transcript, the whiteboard that I collected, and the list of websites that I had shared. You know, and as I share that out, if there's anything else that occurs to you that you want added to the list, just reply to me, and I'll go ahead and get that added. Eventually, I'll post this entire document on the focus group event website so that you're able to find it, you know, if we add additional resources moving down the line. But thank you very much for joining us today. I thought this was a great conversation, and I'm really excited to see how far you can all take this.
Thank you.
Thank you
very much.
Bye, everyone.
Thank you, everyone. Bye-bye.
Bye. Goodbye.
Bye.
Bye.
Goodbye.
Thank you. Goodbye.
Thank you.